Before you make another night guard, finding the real cause of bruxism. Our podcast episode, what underlying factors are driving a patient's clenching and grinding behavior? And how can general dentist identify those factors before simply treating the consequences? Welcome everyone. My name is Dr. Kareem Abraham. I'm a diplomat of the American Board of Dental Sleep Medicine, practicing in Orange County, California, and currently a resident in the Orofacial Pain and Oral Medicine's Master's Program at the USC Herman Ostrow School of Dentistry. I also want to thank the USC Orofacial and Oral Medicine Department and our faculty for supporting this project. I'm here with Dr. Salome Masrani.
Hello, I'm Salome Masrani, and I'm an endodontist based in Austin, Texas, and in my second year of the USC Orofacial Pain Master's Program.
Today, we are talking about a topic that every general dentist sees almost every day, whether they realize it or not, bruxism.
Title today is Before You Make Another Night Guard, Finding the Real Cause of Bruxism.
Exactly. What in general dentistry, we see the consequences all the time. Worn teeth, cracked teeth, fractured crowns, broken fillings, failed veneers, master muscle hypertrophy, and failed night guards. But the bigger question is, why is the patient clenching or grinding in the first place?
That's really the main point of this episode. We are not saying night guards are bad. They are very useful in many cases. If we only make a night guard and never ask what is driving the bruxism, we may be treating the damage without understanding the cause.
So our research question is, what underlying factors are driving a patient's clenching and grinding behavior? And how can general dentists identify those factors before simply treating the consequences?
And we'll focus on causes that general dentists should recognize: prescription medications, caffeine, and dietary stimulants, stress, sleep disorders like obstructive sleep apnea, and recreational or illicit substances.
Let's start with the basics. Bruxism is defined as repetitive jaw muscle activity. It can involve clenching or grinding the teeth, but it can also include bracing or thrusting of the mandible. That definition matters because bruxism is not just tooth grinding.
That's a great point. Many dentists and patients use grinding and clenching as if they mean the same thing, but clinically they're different.
Exactly. Clenching is usually sustained forceful tooth contact without much mandibular movement. I think of clenching as squeezing. It often happens during the day with stress, concentration, driving, working at the computer, studying, or focusing. Grinding involves tooth contact with movement, usually side to side, forward and backward. I think of grinding as rubbing. It is considered a sleep-related movement behavior. The mechanisms are not identical.
For prevalence, recent data suggests clenching is reported by roughly 1 in 4 adults, and bruxism by about 1 in 5 adults, so this is not rare.
And that's why it matters for GPs. This is not an orofacial pain-only topic. This is a restorative dentistry, prosthodontics, implant dentistry, sleep medicine, behavior health, and pharmacology all coming together.
Clinically, a patient may be experiencing jaw pain, clicking or popping, wake up with sore muscles and a headache. They may come to you concerned about how much tooth structure they've lost over time.
And we should also remember that tooth wear alone does not always mean active bruxism today. Wear can be historical. A patient may have worn their teeth years ago, but the current problem may be different.
That's important. So we need to ask, is this active? Is it progressing? Are new restorations failing? Is the patient waking up with symptoms? Are they reporting daytime clenching? Are they breaking appliances?
And that takes us to the main clinical idea of this podcast. Don't jump straight to the treatment. Start with investigation. How do we find the cause when a patient presents with bruxism? Many dentists focus immediately on the bite or the night guard, but the answer may not be in the occlusion. It may be in the medical history, the medication list, the coffee cup, or the patient's sleep pattern.
So what history should the general dentist collect?
I would break it into 5 areas: medical history, medication history, social history, sleep history, and dental history. First, the medical history. Ask about anxiety, depression, ADHD, PTSD, chronic pain, migraine, fibromyalgia, neurologic disorder, and sleep apnea. Many conditions associated with bruxism are not dental conditions.
Second, medication history. And not just, are you taking any medication? Have you started any new medications in the last few months? Any antidepressants? Any ADHD medications? Any sleep medications? Have there been any dosage changes? Have you stopped any medications recently?
The timing matters as much as the medication. A patient may say, I started grinding 3 months ago. Then you find out they started an SSRI 4 months ago, or increase the dose around the same time.
Third, social history. This is where patients often forget things unless we ask specifically about coffee, espresso, energy drinks, pre-workout supplements, caffeine pills, nicotine, vaping, alcohol, cannabis, cocaine, methamphetamine, MDMA, and other recreational substances.
And the way we ask matters. If we sound judgmental, patients shut down. I like asking, walk me through a typical day. What do you drink? What medications do you take? And what substance do you use from the time you wake up until you go to bed?
That is much better than just asking, do you use drugs? Patients may not think of a pre-workout supplement, nicotine pouches, or cannabis as relevant to dentistry.
Fourth, sleep history. Do you snore? Has anyone witnessed apnea? Do you wake up choking or gasping? Do you wake up with morning headache? Do you wake up with jaw pain? Are you tired during the day? Have you been diagnosed with OSA?
And fifth, dental history. Have you worn a night guard before? Did it help? Did you stop using it? Did it break? How many have you gone through? Have you fractured teeth or crowns repeatedly? Have you had any implant complications?
That history is powerful because if we understand the pattern, we can stop treating every patient like the same bruxer.
Now let's move into one of the biggest hidden categories, prescription medications.
This is where many dentists miss the connection.
The literature most commonly discusses antidepressants, especially SSRIs and SNRIs. SSRIs include medications like fluoxetine, sertraline, escitalopram, and paroxetine. SNRIs include venlafaxine and duloxetine. Exactly. Antidepressant-associated bruxism is under-recognized. The mechanism is not fully understood, but one common explanation involves altered serotonin-dopamine balance in the central nervous system. Increased serotonin activity may suppress dopamine pathways involved in movement control, which may contribute to jaw muscle activity.
So for a GP dentist, the clinical pearl is not to diagnose the patient's psychiatric medication as the cause immediately.
And we should never tell a patient to stop an antidepressant. That is outside our role. But we can communicate with the prescribing physician if the timeline strongly suggests medication-associated bruxism.
Exactly. We can say, the patient reports new onset jaw clenching after starting this medication. Would you consider whether the medication could be contributing?
Another important group is ADHD medications. These include amphetamine-based medications like Adderall and Vyvanse, and methylphenidate medications like Ritalin and Concerta.
These can increase central nervous system stimulation. In a susceptible patient, that may contribute to daytime clenching, jaw tension, and muscle fatigue.
This is especially relevant now because more adults are being treated for ADHD. A patient may not connect their stimulant medication to jaw symptoms.
We identify the pattern and coordinate care. Now let's shift to something patients often don't list as medication, caffeine.
Yes, caffeine is huge because patients don't think of it as part of their medical history. Coffee, espresso, energy drinks, caffeine pills, and pre-workout supplements can all matter.
And it's not just, do you drink coffee? It's how much, how late, and in what form.
Exactly. 1 cup of coffee in the morning is very different from 4 coffees, a Celsius, and a pre-workout supplement. Energy drinks and pre-workout supplements can contain high caffeine loads and other stimulatory ingredients. These can increase sympathetic activation, restlessness, sleep disturbance, and jaw muscle tension. For the podcast audience, I would say caffeine and stimulant intake may not be the only cause, but it can lower the threshold for clenching in susceptible patients.
And alcohol?
Alcohol can fragment sleep and increase arousals. Since sleep bruxism is often linked to arousal activity, alcohol may worsen bruxism in some patients, especially if consumed close to bedtime.
Nicotine also belongs here, huh?
Yes. Cigarettes, vaping, nicotine gum, and nicotine pouches. Nicotine is a stimulant and has also been associated with bruxism. Nicotine withdrawal can produce irritability, restlessness, anxiety, and sleep disruption, which may also contribute to clenching behaviors.
So the clinical pearl is, don't just ask what they are taking. Ask what they started, stopped, or changed.
And illicit substances. This is another area where dentists may see oral signs of severe wear or attrition before the patient volunteers the history.
And this needs to be asked carefully and professionally.
Absolutely. The strongest associations are with stimulant-type drugs, methamphetamine, cocaine, and MDMA.
Methamphetamine is probably the classic example, but many only think about caries.
Right. Methamphetamine is associated with xerostomia, high sugar beverage intake, poor oral hygiene, rampant caries, but also bruxism, clenching, muscle hyperactivity, TMD symptoms, myofascial pain, and trismus. Exactly. Cocaine is another stimulant associated with oral complication. It's a stimulant and it reduces blood flow to the oral tissues that contribute to jaw clenching, bruxism, tooth wear, tooth fracture, periodontal issues, and mucosal injury, depending on the route of use.
How about MDMA?
MDMA, or ecstasy, is strongly linked to jaw clenching and bruxism. It is one of the most classic recreational drugs associated with clenching. Patients may also experience xerostomia, increased intake of acid or sugary drinks during use, which compounds dental damage.
So the combination becomes dangerous. Dry mouth, acidic drinks, high sugar exposure, and heavy clenching.
Exactly.
What about cannabis?
Cannabis is a little more complicated. Some patients report cannabis helps them relax, sleep, or reduce muscle tension. Other studies suggest cannabis users may have increased risk of bruxism or other oral health issues in certain populations, so the evidence is mixed. This is where we need to be precise. I would not say cannabis withdrawal directly causes bruxism because the direct evidence is limited. But cannabis withdrawal commonly causes anxiety, irritability, restlessness, disturbed sleep, insomnia, and physical tension. So the takeaway is stimulant drugs like methamphetamine, cocaine, and MDMA have stronger evidence for jaw clenching and bruxism. Cannabis is more emerging and mixed. Nicotine belongs in the moderate evidence category.
We also need to talk about stress because it's the explanation patients and dentists jump to first.
And stress absolutely matters. Clenching is commonly associated with stress, anxiety, emotional tension, concentration, and coping behaviors.
But the problem is when stress becomes the only explanation.
Exactly. Saying it's stress may be true, but it may not be the whole picture. The patient may be stressed, also drinking 600 milligrams of caffeine a day, taking an SSRI, using nicotine pouches, and sleeping poorly.
That's a real-world patient.
How can we...
For clenching, I like asking patients, when are your teeth touching during the day? Ideally, the teeth should only touch while eating, but otherwise remain slightly apart. Many patients are surprised by that. If the patient catches himself clenching during emails, driving, charting, we can start habit reversal. This is where sleep comes in. Bruxism is different from clenching. It's not simply a bad habit during sleep. It's associated with central nervous system activity, autonomic activation, and microarousals. Obstructive sleep apnea, or OSA, is common in adults, and sleep bruxism and OSA can coexist. Some studies suggest many bruxism events occur near arousals, and in some patients, those arousals may be respiratory related.
But we should be careful. Not every bruxer has OSA, and not every OSA patient bruxes.
Exactly. The message is not bruxism equals sleep apnea. Morning headache, jaw pain, snoring, and witnessed apnea, daytime sleepiness, obesity, hypertension. The dentist should consider screening for OSA.
Ask.
Simple ones. Do you snore? Has anyone seen you stop breathing? Do you wake up gasping? Do you wake up with morning headache? Are you tired during the day? Have you ever had a sleep study?
That makes it very practical.
And if the patient screens positive, refer for appropriate sleep evaluation. We are using dental findings as a reason to ask better questions.
Now let's answer the big question. What should the general dentist do?
First, protect the teeth, but do not stop here.
Exactly. Occlusal appliances can be helpful to protect teeth and restorations, but the night guard is not always treating the cause. It may be protecting against the consequence.
So management should be layered.
Layer 1, education and awareness. Teach the patient that teeth should not be touching at rest. Use reminders, habit reversal, phone alerts, or stickers on the computer that say lips together, teeth apart.
Layer 2, review medication. If symptoms begin after SSRI, SNRI, or ADHD medication change, communicate with a prescribing physician. Do not tell the patient to stop medication yourself.
Layer 3, review caffeine, energy drinks, pre-workout supplements, nicotine, alcohol, and recreational substances. Discuss timing, amount, and possible reduction when appropriate.
Layer 4, screen for sleep disorders. If the patient snores, has morning headache, daytime sleepiness, witnessed apneas, or uncontrolled hypertension, consider sleep referral.
Layer 5, manage the musculoskeletal system. Depending on the case, that may include thermal therapy, switching to a soft diet when there is tenderness in the jaw, stretching, massage, physical therapy, trigger point management, or orofacial pain referral.
Layer 6, restorative planning. If the bruxism has already resulted in severe wear of the teeth, major restorative work, veneers, implants, full mouth rehab, needs careful risk discussion and protection.
And monitoring is key. Make the patient change caffeine, medication timing, or sleep care.
If a GP dentist remember only one thing, remember these 5 questions.
Have you started, stopped, or changed any medications recently?
How much caffeine do you consume daily, including coffee, energy drinks, and pre-workout supplements?
Do you use nicotine, cannabis, or recreational substances?
Do you snore, have sleep apnea, wake up tired, or wake up with a morning headache?
Have you broken teeth, fractured restorations, or gone through multiple night guards? And they move the dentist from simply treating damage to identifying the driver.
Are dentists over-attributing bruxism to stress while overlooking medications, sleep disorder, and lifestyle factors?
I think yes. Stress is real, but it can become a shortcut explanation. If we blame stress too quickly, we may miss other factors.
Matters in restorative planning, but bruxism is not simply an occlusal disease. The current understanding is much more central, behavioral, pharmacologic, and sleep-related.
Are we making too many night guards without identifying the cause?
Probably. Again, night guards are valuable, but a night guard without a diagnosis is incomplete care. If the patient is wearing through the appliance breaking teeth, waking with headaches, snoring heavily, we have to look deeper.
As important as treating the consequence.
Thank you for listening. This was Dr. Kareem Abraham
And Dr. Salome Masrani.
and this was Before You Make Another Night Guard, Finding the Real Cause of Bruxism episode.